Good morning. It is 10 o'clock and it's time for our weekly coronavirus virtual information session. We want to welcome you all on this beautiful day. We have special guests here today, we have Laura Morton, who's going to give us an update on what's going on in our nursing homes. And then we have Dr. Ted Smith that I will introduce in a minute. So before we start, let me just give you a few rules here. Please mute your mics if at all possible, and keep your video off if you do not want to be recorded. If you don't mind that, then it's nice to see everyone's faces. If you have a question, you can type it in the chat room, and then when both our speakers are done, we will have time for questions. And then if you are concerned about your health, you feel welcome to call us at 588-4340 or call the Kentucky COVID-19 hotline at 800-722-5725. And then if you have issues with your sound, make sure you look here where you can change any issues you may have by clicking on that little arrow to do a test. And then lastly, if you can please type in the chat the county that you come from, it just helps us to know who we are reaching. So thank you. With that, I'm handing it over to Laura Morton to give us an update on what's going on in the nursing homes.
Good morning, everyone. Thank you for having me here today, Anna. I'm Dr. Laura Morton, and I am Division Chief for University of Louisville Geriatrics. I'm a geriatrician and work primarily in the post-acute and long-term care settings, and I'm happy to be here today. I just wanted to let you all know just an update about the Optimal Aging Clinic, that it is now open and there's a provider there in person. We're still mostly doing telehealth visits. However, there's someone in person in the office to meet your medical needs. So we would encourage you, if you have needs, to give us a call and come on in. The biggest news, I think, as you all are aware of, is this Memorial Day weekend, and Governor Beshear started opening up Kentucky. And I think lots of things are opening in a phased manner. The biggest thing that came and the biggest update is now that we are allowed to gather in small gatherings, less than 10, and you want to try to limit those. But the guidelines that Governor Beshear gave us were hands, so to wash our hands frequently, face, to wear a mask when we are with those small groups, and to remember the social distancing space of 6 feet. So that's important as we're getting together and opening things up, that we remember those guidelines. Also, an update from the governor's long-term care task force, which Dr. Furman and myself are on, that as you all have seen in the news, there has been continued testing across the state, and the goal is to eventually test all of the residents on all of the long-term care facilities in Kentucky, which is about 300, and to test the staff members. And as I'm sure you've seen in the news, that there continue to be more positives coming from those facilities, and they are being addressed by each facility. Presbyterian Homes was tested last Friday, as was Episcopal Church Home. So the results are still pending. As far as I know, we haven't gotten those back yet, but we'll see what happens. And again, it was all for screening purposes. There were no suspected cases, but that's the plan for the governor to go across the state. On the long-term care task force, we are also going to start looking at how we reopen the nursing facilities, which again is going to be a challenge. The nursing facilities have been about 8 weeks without visitors, with restricted vendor policies and everything to try to limit the spread and minimize anything being brought into the facilities. So the long-term care task force, I think we're going to start looking at what are the ways we can do this safely and how we can bring people back into the facility. And I think that's the COVID update for the week. And thank you all, and thank you, Anna, very much.
Thank you, Laura. She is available until about 10:30 to take any questions. And then after that, Dr. Furman, who's on the road to Miami, will take the calls, or any questions, I mean. Thanks, Laura. Now it's my honor to introduce to you Dr. Ted Smith. He is an associate professor of environmental medicine and the deputy director of the Environment Institute at the University of Louisville School of Medicine. His research program is on health technology, community engaged research, and research translation. Ted also served as the Chief Innovation Officer for the City of Louisville, where he created the largest real-time asthma surveillance research program, AIR Louisville. Ted received his BS in biology and psychology and his MS and PhD in experimental psychology. And he did some postdoctoral studies also at the Massachusetts Institute of Technology. And this morning, he is going to talk to us a little bit about COVID-19 and the Co-Immunity Project. Welcome, Dr. Smith, and we are waiting to hear from you.
Great. Well, thank you so much for having me. I assume you can hear me okay?
Yes.
A nod, thank you. Very good. So it is a pleasure to join you. This is a wonderful series that you have at the Trage Institute, and I'm delighted to be part of your continuing tradition here. So first of all, I want to sort of introduce the Co-Immunity Project really a little bit by way of historical background. So it may not be common knowledge that in the earliest days of the coronavirus, many of my colleagues here at the University of Louisville in infectious disease and virology had stepped up at a very important time, which really has enabled us to have the opportunity to do the work that I'm going to share with you today. But I want to start with a real acknowledgement and profound gratitude to Dr. Julio Ramirez, Dr. Forrest Arnold, and Dr. Ruth Carrico, because their work in those early days when commercial labs neither had the lab kits nor the turnaround time to meaningfully impact the testing of healthcare workers and the testing of many patients who were symptomatic that were presenting in the emergency room. If it were not for efforts to do testing at the university, we very well could have had a significant problem in our healthcare settings because of sidelining people that we had to be overly cautious about until we had their test results. So those labs, run by Kenneth Palmer and Hoon Chung, the Center for Predictive Medicine, had built an apparatus. Essentially, I think we're all used to the notion that the Wartime Production Act, was re-engaged to help us build ventilators at General Motors and all these kinds of fun stories. But, I think we've had our own version here at the University of Louisville, and I think it was remarkable, heroic and timely work to essentially convert research testing laboratories into, surrogates for commercial labs that just could not possibly handle the demand. So I had the privilege to work alongside that team at the sort of end of March and early April, and it became clear that it would be important for our community to not only look at testing for active infection, but also begin to get a snapshot of past exposure to the virus. So looking at antibodies in various populations. And so the Co-Immunity Project is named, it's maybe a little too clever. So it has community in it, and it has immunity in it. So co-immunity is community immunity, hard to say. And really our interest is in understanding immunity in these various populations, because I think we all know that the path out, really will require a vaccine or some very effective treatment in order to minimize the loss of life based on what we seem to know at this point in time about immunity to the virus. And, it's a novel virus, meaning, we don't fully understand, why children who are often vulnerable populations are seemingly less vulnerable in this case. So we learn more every day about that side of immunity. We certainly know that older populations with underlying conditions have a kind of immunity compromise that makes them more susceptible, and that's obviously a matter of great concern for us all. So this idea of wanting to get a picture of what the total exposure has been to the virus, the people who maybe have been asymptomatic and survived, these are not individuals that are counted in the current testing framework. Because of the scarcity of tests early on, I think we all realized the only people that were eligible for testing were people who were symptomatic. And that means in the United States, it's been very difficult to get a handle on the total exposure, which would include those people who were not symptomatic when infected. Now, we know from other countries that there is a population that survives infection without symptoms, and that number varies pretty greatly depending on the country and study you're looking at. But I believe at the low end, it's something on the lines of 10%, and at the high end, it's 30%. And so we're very curious to know in Louisville and then ultimately in Kentucky, what that total exposure has been. Okay, and then what the characteristics are of those people who have survived infection with these different levels of reactivity. So the co-immunity project has two phases. Phase one is a focus specifically on the healthcare worker population, and that's of great interest to us all because the healthcare worker population is probably the most exposed population in the United States. And so, because these are the individuals who have the most proximity to people who are infected and the most opportunities, whether accidentally or not, to acquire an infection. And so it's important that we start with a defined population to understand, again, both active infection, and these workers are often tested on a pretty regular interval anyway for active infection, but they're not tested, as a matter of course, for past infection for antibodies. And so this project, which is a bold partnership with the Louisville Healthcare CEO Council and the Envirom Institute and the Center for Predictive Medicine at the University of Louisville, is to focus on recruiting any healthcare worker in the Louisville metro area who wishes to be tested. And then they get delivered to them a kit. They do self-testing. They're healthcare workers. This is one of the few times where it's really handy from a testing perspective to have healthcare workers being the subjects of the work, right? So they get kits. They get to test themselves, and that's a nasal swab and a small blood sample in a vial. Not a blood draw with a needle, but it's more of a finger milking kind of a blood prick sample. And so we've had, I don't have the exact number in front of me, but I believe over 600 healthcare workers in the Louisville area participate to date. We'll be wrapping up this phase of the work in the next few weeks. If you go to the co-immunity project website, if you're a healthcare worker and you're interested in participating, there's a way for you to raise your hand virtually, and we can reach out to you and make sure you get a kit. What we're learning in phase one is that even though this is the most exposed population, kind of in our community, levels of past exposure seem to be fairly low, and not that we're completely shocked that that's the case, but it suggests that there's going to be a long road while we, again, wait for a vaccine or wait for an effective treatment, a long road of caution that is going to be important because we have people who have not been infected. And, I know many people have heard the term herd immunity and the idea that short of these other treatment or prevention measures, we wait for enough people to get exposure and build antibodies that there's no transmission that's possible. That would be this herd immunity notion. Unfortunately, herd immunity is north of 60–70% of the population would need to have antibodies, would need to have been exposed. We seem to be very, very, very far from that. And so I would say that's one thing we've learned from the first phase with healthcare workers. The second phase is the kind of thing that you might have expected our own CDC in the United States would have done a long time ago, and that is to try to establish the general prevalence of the virus in the population. And so just like we were focused on the healthcare workers as a population, we don't know the answer to what total exposure has been in the broader community. And so phase two is randomized testing of the general public. And I'll just share a little bit about that today. We'll be having a series of announcements about it as we launch that officially. But But essentially the idea is the testing that we have done as a community, has been focused on folks who are symptomatic, right, who are presenting symptoms that appear to be coronavirus symptoms. We have been testing certain kinds of workers who have proximity, to folks who could be vulnerable or could have been infected. Increasingly, we're having occupational testing. So again, for certain kinds of jobs, more broadly, more regular testing, to make sure that we catch somebody who has contact with multiple people, catch those kinds of individuals early in infection. And then we have these drive-up tests that are available at Kroger and these other places. And that's, for, we call that, convenience sampling. Those are people that are curious, concerned, and are taking the initiative to go seek out a test. What we haven't had in the United States is randomized sampling of the population. And randomized sampling is invitation to somebody who might not have decided they needed to go get a test. In fact, the vast majority of people who will participate in a methodology like this probably wouldn't go seek a test. And that means we don't know about those in our community who've been exposed, who survived infection, did not know it. I mean, just imagine, like, perhaps sometime in January, you were very, very sick. And this was before there was any notion of testing for the virus, within the United States. So you could have had potentially an infection, a coronavirus infection, and you would have been missed in the total counting of those tested. And so this process of testing a representative, think of it like political polling, a representative sample of Jefferson County, so that if we find, 5% are currently infected, and if we found 7% have antibodies showing past infection, and if we did it in a statistically representative way of the entire community, we could estimate the actual number of people in our community today that have infection and accurately estimate how many people have survived infection. And if we did that on some kind of a regular basis, maybe every 6 weeks, as we are concerned about a return of the virus in the fall. Remember, we think viruses like this, tend to migrate around, so they may spend some time wintering in the southern hemisphere and may return with gusto in the fall. That's one model of this virus. Then we hope to be in a better position as a community to understand when things are trending in that other direction, a second surge, if you will. We really were caught off guard this time, and we're really unable as a country to identify, what these surges were like. We had all these models that people were looking at, but we didn't have necessarily the right kind of testing framework in place. Well, now we have that chance. We have that chance here in Louisville to do this first. I really hope that many other communities will want to follow the work that we're doing here and include this in their own testing framework as communities. And then last, we have a piece of this project that is focused on learning more about the role wastewater may play in a testing framework. And many other countries have been actively exploring and testing their wastewater. And it seems the early data seems to indicate that certainly the virus can be detected in wastewater. And it seems to be broadly correlated with prevalence of infection in the communities they're testing from. So if this wastewater work, if it continues to appear to be as promising as it is, it can be an additional layer of surveillance and monitoring on top of all this individual testing, which is an exhaustive, logistically complicated, expensive process. Obviously, if we can find other ways of passively monitoring infection, both in space and time, that could be a remarkable breakthrough for the way that we understand what's going on. So that investigation work is one part of the overall community project. So the project, as I said, phase 1, is wrapping up with the healthcare workers. Phase 2 will start in the month of June. and we will repeat that sampling as often as we can, as we have resources that allow to get as many data points as we can, leading into the fall. So I'm a little winded from my speed talking, so I will. I'd be happy to take any questions or any topics people want to explore.
Thank you, Ted. I really appreciate this discussion. It's been very helpful for all of us to understand a little bit more about these numbers. And there's a lot of questions in the chat. So I'm going to ask Justin to start directing us to all those questions and see if we can get some answers from you and from any other of our colleagues who feel they want to comment.
So Dr. Smith, there was a Courier Journal article that basically discussed that deaths due to pneumonia in Kentucky are up over the last 3 months, and many of these individuals tested negative for COVID, but now there are speculations that there's a high false negative rate for these tests. Is this really important to consider in order for us to understand the disease?
Well, I can't comment specifically on the pneumonia testing, but I will say that it is important for us to get a good snapshot of our past. Like I said, in the January, February, early March timeframe, it's just really unclear, what the prevalence of the virus was in the United States. And I think the single smartest thing that we can do is high quality antibody testing, again, of a representative group, so that maybe we can answer some of that question. Was there any sort of missed virus in our community for some people? The whole area of testing, as you know, has been a really controversial matter, and there's a great interest in having more portable testing, low-cost test kits, those kinds of things. Just so that everybody knows, our project is laboratory testing only, so we're doing very high-end, complex PCR testing for the virus. And then for antibodies, similarly, those blood tests are going back to an ELISA test facility, and it's the highest quality testing you can do on antibodies. So hopefully this project will help us answer questions like that one.
And just because you test negative when you're tested, it doesn't mean that you could not eventually get the coronavirus, correct?
Yeah, so I think there are two circumstances with a negative test, right? One is you are truly negative, right? Meaning you don't appear to be actively infected and have no level of virus in your body. There are people early in infection who may test negative because the load of the virus in their body isn't sufficient to be detected by the test. And so this is why people who test negative, who continue to present symptoms that are troubling, need to be tested again. So yeah, we always want to be vigilant of the idea of a false negative.
And then what will it take to determine if IgG antibodies indicate lasting immunity?
So what it will take is time. And so we really have to get more time experience to see the nature of protective immunity. So it is too early to tell anything about protective immunity. I will say we've gotten beneficial immunity from convalescent plasma donation. So the healthcare workers that participate in this project who have been infected and have high levels of antibodies, they've certainly been encouraged to and invited to donate their plasma for treatment of those who are very sick with infection, and those results have been very promising. It's certainly not as scalable as a vaccine or a commercial drug treatment, but it's something that can be done now. So at least we're seeing short-term immunity benefits from the antibodies that people have, but the jury's out on what the long-term immunity will be.
And someone mentions that they saw people discussing on social media that some studies are showing there's no such thing as an asymptomatic carrier. Can you speak to this idea and whether it is misinformation and why?
Well, it's very difficult to definitively answer those kinds of questions. So when people have been tested and are positive for coronavirus antibodies and ask if they ever had symptoms, respiratory or GI symptoms, and those people say, no, I didn't, it is really impossible for us to know, what that person's status was in the past, right? And so, this is just an issue with, what's knowable and not, based on the kinds of cross-sectional studies that have been done to date. So, my personal opinion is I believe there are people who get infected who have very low levels of symptoms that they don't, recognize. But this idea that we know one way or the other definitively is, I think there's no basis for that.
Thank you. So if there's no randomized sampling in the U.S., wouldn't that suggest our current numbers, U.S. and local, are a stark underestimate of coronavirus cases?
Well, I think the reason to do this work is to answer that question. I mean, you can do the speculation going either way on this. So you can, if you believe there was a whole lot of exposure that was asymptomatic, then you would think that we've undercounted. If you think that that's not true, and that, really we have the most symptomatic people have been presented and tested, then I don't think that we have miscounted. So, it's just important to get this data. That's really the point. So I don't want to speculate on what's likely to happen. I mean, this is science. We dispassionately approach this, and if we do this right, we get the truth.
Is there an actual blood test for determining whether you have or had a coronavirus? If so, where can you get it?
Yeah, so that's the testing that we're doing as part of this project. So it's called antibody testing, and there's two ways that I know that you can get antibody testing, and that is one, you can participate when invited to participate in the community project. So we'll be mailing thousands and thousands of people in our community invitations to participate, and for free they will be tested for the virus and for antibodies. The other way, if you're not invited, is to contact your provider and inquire to see if they'd be willing to do the test for you. And, often if you've been symptomatic in the past before tests were widely available, you may have a provider that says, this may be worth looking at to try to get an understanding of what you've been through.
Is there any effort locally with MSD to do wastewater testing?
So we've begun investigating, the university has, with MSD on the feasibility of wastewater testing. So that initial investigation work is ongoing. A lot of this is just really directly related to the quality of the science and the feasibility of doing the work. And, obviously caring greatly for the frontline workers at MSD who would make that kind of work possible. So it's something that's under investigation right now, and we're moving as quickly as we can to figure this out.
Is there a recommended frequency of testing for asymptomatic people who test negative?
To my knowledge, there's no recommended frequency. I'm only aware that in certain kinds of occupations, some employers have come up with rubrics for how often somebody may need to be tested. I think we're all familiar with the news out of the White House that everybody there gets tested every day. So there's a version of that in other kinds of occupations, I'm sure. But there's not general guidance about testing and retesting.
And will the co-immunity project only be in Louisville or statewide?
So with the funding that has been raised to date and identified to date, it is only in Jefferson County. I cannot emphasize enough how important it is to do this work statewide and in other states. And so our team, the co-immunity project team, is very happy to engage with any other county, with the Commonwealth directly, or with any other state that's interested in doing this work. It really doesn't do us a lot of good in the big scheme of things if we don't all adopt this kind of statistically reliable measurement.
Any more questions from anyone?
So there's two more comments. Oh. So if you think you possibly had the virus in January, is the antibody testing going to be able to test that far back, and how long do antibodies remain in the system?
Yes, so that's related to the earlier question, how long might somebody be able to retain immunity after infection and development of antibodies? We don't know a lot about the temporal aspects of antibodies in this particular infection. there's not reason to believe that you would not be able to still detect antibodies from somebody who was infected in this year. But again, I don't think the definitive work has been done on that. I think just convention and looking at viruses that are similar to this one, you would expect you would be able to see antibodies from that recent past exposure.
So there's a question about, can you speak more about what other countries have seen with community prevalence regarding wastewater studies? And I'm going to add my own question in this. Are other illnesses or viruses being tested in a similar fashion?
So on the wastewater side, many cities around the world have been essentially testing citywide representative samples. So by that I mean, in a large city, there's usually one or two very, very significant wastewater treatment facilities that all the sanitary sewer lines lead to for processing. And samples have been taken in many cities all around the world on a weekly basis from those central wastewater treatment facilities. And what we do know is that so far we've seen an increase in viral loads in all of these other cities that are commensurate with the other background testing they've done or foreground testing they've done of their population. So there is a relationship, meaning if you see virus in the community, in the population testing their noses, you will see virus in the wastewater. That, from my perspective, just an editorial comment, I mean, that's great if you want to answer a very broad population question. So is there, a trending increase or trending decrease in virus amount in a city over time? And imagining the best case scenario is to eradicate the virus and it goes to zero. So there's certain people that, of course, are interested in questions that are just very broad like that. Is there increasing infection in Philadelphia or decreasing infection in Philadelphia? Functionally, that's not as helpful if you're trying to combat the virus, right? So combating the virus, has this notion of we really need to identify who's infected and as quickly as possible isolate, contain, and eliminate the threat to the rest of the population, right? And so most of the epidemiology work done with wastewater today doesn't have that kind of spatial functional layer to it. So this is something we're interested in having a much better handle on. The question about whether other kinds of infectious disease, have been explored through wastewater, there have been other viruses that have been looked at by other communities, not on any sort of scale, but it's an emerging field. It's called wastewater-based epidemiology, and it's like I said, it's an emerging field. Certainly, this pandemic has accelerated a lot of the interest in how it could work.
So, what is the best way for other counties to contact you if they are interested in participating?
That's a good question. So, if there are other counties that are interested in participating, I would encourage them to come to the Co-Immunity Project website and go ahead and indicate what your interest is. There should be a place for you to fill out a form, about your interest in the Co-Immunity Project. And if you're coming from another county, your interest is, how do I get this to my county? And that should find its way to me and some of the other investigators on the project.
Do you mind putting that in the chat, and we'll make sure that gets on our website?
Sure, be happy to.
So any speculation when things may return to normal, or is it your opinion there will be a long time of uncertainty and therefore we need to be careful how we engage?
Well, I mean, I think we all understand that caution has been the smarter side of action at the moment. And so until we have a better understanding, I think we're in a position where we need to be cautious. And this is especially true given, the disproportionate burden that it's having on older populations, folks who have compromised immune systems. This is, this isn't really something to take lightly. I think the good news is in 2020, I think we have the tools and the sophistication to act to do our best to protect ourselves from this and to protect those who we love from this. So, you know, I think until we have more information about the nature of who's truly vulnerable and how transmission really seems to be working, I think cautiously proceeding, which is what we're doing now, cautiously reopening our economies, heading into the warm weather, cautiously imagining if it's like some of these other viruses, we could end up with another spike in the fall and the winter. You know, this is how we have to approach this. I think we have to approach it cautiously, smartly, really trying to get the answers. I mean, just to be clear, this project really came from a need to get more information about this virus, right? Who is vulnerable? You know, who is immune? How does that immunity work? How can we understand how it's actually preferentially finding hosts in some and not in others?
Dr. Smith, I think you're frozen, or am I frozen? Dr. Fall, did we lose Dr. Smith?
I lost my internet as well for a minute, so I'm not sure. Is he gone?
I'm scrolling through the participants and I don't see him.
This is Sam. I think we lost him.
Okay,
He will probably get on the list.
He will probably get back on. I lost my internet connection as well during the same time he lost his. So, but is there any other questions maybe for, I think Dr. Furman is still, yeah, she's on the phone. Any questions maybe for Dr. Furman while we're waiting for Dr. Smith to get back online? No? All right.
This is Dr. Furman. I just wanted to give everybody a reminder that the hospitals are starting to change their visiting policy. So each person just should contact the individual hospital that they're going to. But U of L, I haven't gotten the latest, but they were going to reconsider their visiting policy and make some announcements this week about the new visitation policy. But our office is still having the same policy where our waiting room is closed and people are waiting in their car. And that's pretty much what all the doctor's offices are doing. So just encourage you all to, call your doctor before you go, call your provider before you go so you know if you're going to be waiting, how the procedure is. But everybody should be wearing their mask when they go out, and especially when they go to their doctors and their providers. So things are, just starting to change week by week, I think, as time goes on.
Yeah. Thank you. Thank you for that update. Any other questions or comments from anyone? I don't see Dr. Smith back online yet, so he's maybe struggling. Okay, he's trying to rejoin. Okay, all right. While we're waiting for him, people can keep putting any questions in the chat. I just want to say that our focus is going to be in the next few sessions on all these questions related to reopening our economy. And next week, we're actually having Stacy Roof, the Kentucky Restaurant Association, who's going to talk about the reopening of restaurants and what are all the challenges that they are facing. So we're really looking forward to that. We're also going to have a panel shortly about opening of churches from the different faith communities in our area. And then also the healthcare reopening. We're going to have another panel on that. So we hope to really engage with all of us now in this challenges we have with the reopening, having to take this virus seriously and be slow in how we re-engage with our communities. So I hope you will be interested in hearing that. I still don't see him. So he may have lost internet completely. Okay, so Justin, there's a few more questions. I wondered if you maybe can ask that.
Yeah, I'll start with reminding everyone if you or someone you know is providing care to a loved one who is 60 or older, the Trage Institute has a free caregiver program. The caregiver team can provide the caregiver with referrals, resources, training, and support groups. The caregiver team can be reached by calling the caregiver hotline 588-3322 or emailing tragerinstitute@louisville.edu. A question from Barbara about, and I'll circle back around to Andrea's question. I get them out of order. How safe is it to go to the dentist, and what are their practices during this time?
Dr. Furman, would you like to comment on that?
Yeah, the dentists, are open, but it's up to each practice. So they have to follow the proper PPE. And so, the dentist practice are all wearing their mask. It depends on what procedure they're going to do because, the mouth does have, potentially more exposure. But really the dentists are wearing the N95. It depends on what procedure they're doing, but the dentists that have, they know what procedure they're doing and how much exposure it's going to give to really it's giving the exposure to the dentist and the dentist staff. So they are wearing more of those N95 masks if they're going to be doing something more invasive. But yeah, people should not delay their dental care. It's the same as their medical care. People have been delaying all of their care and then end up sicker and worse off. So we want people to go to their dentist and get definitely their routine cleanings are able to be done, no question, as long as the dentist has the proper PPE. But, people have abscesses and infections in their mouth, which can lead to, really overall bad conditions if you don't get it taken care of. So we recommend everybody, keep up with their dental care, keep up with their medical care. This is going to go on for a while. And I think at first, we just shut everything down, which was appropriate. But now we can't just keep delaying routine care because then people are getting sicker and sicker.
To that point, I can just also say that Dr. Hill from the School of Dentistry will be with us on June 16, and she will also be able to talk to you all about the reopening of the dentistry offices. So maybe that could be helpful for people.
That's good, yeah.
So what's the most important thing we as healthcare workers can share with our community members regarding social behavior as things are opening up?
I think the big thing is people have to, don't go into crowds more than 10. It should be less than 10. Dr. Jen Cook at U of L had a great video that she was interviewed, and that's on the U of L website. But, just because everything is opening up and you can do all the stuff doesn't mean you should do all the stuff. I like what she said was just pick one thing that you want to do and do that. You don't have to do 10 things in one day because you still want to limit your exposure. So pace yourself, only have, like I said, one exposure a day. And also the time that you're exposed makes a difference. So you just want to go in and get whatever you're getting and leave, not just, browse the store and spend a lot of time in these stores. So, but when you're out, you have to wear your mask. And you think, oh, you're going to be 6 feet away from everybody. What happens, though, is people drift. Like, you just kind of accidentally get closer than 6 feet. So it's best to always wear your mask when you're out. Wash your hands whenever you touch something. Do not touch your face. I like what the governor said, which was the hands, face, and space. So hands, wash your hands. It has to be, you can wash them with soap and water for 20 seconds or sanitize them with an alcohol-based sanitizer. Don't touch your face. And then the face is the mask, wear the mask, don't touch your face. And then the space is 6 feet apart. So you have to practice all those things and just be safe and thoughtful about what you're doing. And it's hard if you have not been out. I mean, we've been working every day and going to work, so we're kind of used to it. But at first, it's very, very hard. You have to really think through your routine. You just can't walk out the door like you used to. You have to bring your mask with you. You have to plan where you're going. You have to bring your sanitizer with you so that way when you get back in the car, you can sanitize again. So whenever you touch your mask, you should sanitize. So you need to have alcohol on your person, the alcohol sanitizer on your person, the hand sanitizer on your person. You need to have a mask on you. Put your mask in a paper sack and bring the sack with you so you can take the mask off when you get back in the car, because it is hard, and especially as the weather gets warmer and you kind of feel like you're suffocating in the mask. So it's okay to take the mask off when you're in the car, but just put it in a paper sack because the paper sack can breathe. Label the paper sack so everybody in the family, you know, just right there at the door when you're getting ready to exit, have all the paper sacks lined up, labeled with whose paper sack it is and whose mask it is. And the cloth mask, you know, we do have it on our website how to make one, and you should wash that after you use it, you know, and then, you know, wash it every time. So you might want to have a few different bandanas, you know, a few different masks ready to go so you can, you know, have one ready to wear and one in the wash. But it does take a little thought, so you can't just go totally back to your normal routine. You have to have it planned out.
Dr. Furman, do you recommend healthcare workers still avoid social gatherings of 10 or less in this time being, since they work in higher exposure risk areas?
Well, I mean, you know, I think at some point it's an individual decision, but, you know, pretty much everybody's exposed, and the healthcare workers are wearing the PPE. It's amazing, you know, a lot of these healthcare workers have done the antibody testing that we were just talking about, and their antibodies are coming back negative, and they've had a lot of exposure. And so it's because we are wearing the PPE and we do have the appropriate equipment. So I don't, you know, healthcare workers, everybody, you know, I think everybody just has to think individually. If you're symptomatic, you should not be around. And, you know, if you're having a fever, chills, shortness of breath, diarrhea, nausea, loss of taste, loss of smell, you should be isolating. But, you know, even the official guidelines for U of L Health say, as long as you don't have symptoms, you know, it's okay to go to work, but you have to monitor your fever, monitor for symptoms twice a day. But at the very beginning of the pandemic, you know, if you were around someone that was positive, you couldn't go to work for 14 days. But now they're not saying that because really everybody's potentially has COVID and everybody's potentially exposed. So you just have to follow, you know, wear the mask, wash your hands, stay 6 feet away, and just monitor for symptoms.
Should all workplaces environments adopt a routine testing procedure, and what would be considered a best practice for returning to work?
Yeah, I think that's individual. I mean, there are guidelines from the CDC and the state has guidelines. The governor has guidelines and it kind of depends on what work you're doing. But like at U of L Health, you know, we are not testing everybody. You do not have to be tested to go back to work. So it just depends on your employer and what they're doing. So and pretty much there's enough testing around so everybody can be tested if they want to be tested. It's in Jefferson County for sure, but really throughout the state, they have all these testing sites. So anybody can be tested that wants to, but each employer has their own guidelines about mandatory testing, except for the nursing homes. The nursing homes are, going through systematically every nursing home in the state where all the staff and all the residents will be tested. But that's the only employer I know of that, is mandatory, but there might be others. It just depends.
Hey, are there any other questions for Dr. Furman?
Dr. Nash indicated that she may want to comment on the dentist question.
Yeah, just real briefly, two things. I personally have been to the dentist and I was incredibly impressed. Of course, there's going to be high variability, I would think, between offices, but this was a community dentist, and the amount of PPE and precautions that they're taking is pretty, I don't know how they're doing their jobs. I mean, it's significant. So I think if you need to have something done, you can feel fairly confident, and you can always call ahead and just kind of see what their protocol is if you're nervous about that. And then I just wanted to also mention, I did do the testing that was available through ULP, and it does take, just don't, if you do go get tested, understand that it can be 5 days before you get your results. So, and then trying to go back into the system to expedite that is a bit of a challenge. So don't get nervous if you don't get results within 24 or 48 hours. And I'm negative, so that's good.
Okay. Are there more questions here? Seems like we're almost at the end of questions. Justin, do you see anything else?
Kara just commented on what senior care experts provides, and that we'll make sure that we have resources on our website.
Thank you. Thank you. Well, then I think this is the end of today's session. Thank you so much. This was very informative, and we're looking forward to talk next week about the reopening of the restaurants, where we will join you all back into this discussion. Thank you so much, and have a wonderful week.